Um, Good morning, everyone. I want to thank the AFPMB for inviting me to participate in this seminar series. My name is Scott Norton. I am a retired Army medical officer, a colonel, dermatologist with a background in tropical medicine and infectious diseases. And we'll be talking today about delusions of infestations, a dermatologic perspective. And next slide. And that should say no financial conflicts of interest. Next. I was invited, go back one. Okay. I was invited to give this presentation after the 2020 Entomology Society of America annual meeting. There was a several-hour symposium on delusions of infestations that was presented there, and some members of your organization asked me if I would give a more comprehensive perspective at one of your conferences, and so I was delighted to accept that. And but I think that if you're members of the ESA, you may be able to go back into your website and find this entire presentation that's 4 hours long. Next. We had specialists from several fields, not only entomology, but parasitology, science journalism, dermatology, psychiatry, neurology, public health officers who participated in the conference on delusions of infestation. Next. And some of the entomologists and parasitologists that you may know are Gail Ridge from the Connecticut Agricultural Experiment Station, and she was the director or leader of our symposium. Nancy Hinkle, who's a veterinary entomologist at University of Georgia. Richard Pollack, who was the state entomologist from Massachusetts and now works in environmental public health at Harvard. And Bobby Pritt, who is a clinical parasitologist at the Mayo Clinic. Next slide. The talk that I gave was sort of on the interface between infectious disease, parasitology, entomology, and dermatology. I called it The Doors of Perception, Clues to Distinguish Real from Imagined Ectoparasitic Infestations. The presentation that I'll be giving to you is a greatly expanded version of that 15-minute talk. And you may see a lot of slides in the background that have the ESA logo, and some of them are slides that I showed, and many of those are just slides that I've added for this, but I had that template already embedded in the presentation. Next slide. Well, first of all, we have to get into some definitions. What's the name of this condition? My title is Delusions of Infestations, but this condition that we will be talking about has a handful of names. Next slide. This is okay, so here we have what NIH calls this, delusional parasitosis, and the National Library of Medicine at NIH has 39 synonyms that are used in the medical literature. Next slide. There's been an agreement in this world that to call it delusions of infestation as sort of the current rubric, although when I give this presentation and when you read anything on this, you are going to hear many other terms, but it's sort of one of those things like the Supreme Court definition of pornography. You know it when you see it. Next slide. I do admit that as a clinician, I like to use the word concern for infestation because I'm talking with patients, their family members, and oftentimes my notes, I try to be very candid with everybody with complete transparency. So rather than using words like delusional or psychotic, imaginary, I use concern for infestation, and that in a broad sense would include both real and imagined infestations. Next slide. So we're going to use this algorithm just to start out conceptually. Here we have a patient who's concerned for infestation, and they can present oftentimes to the clinical provider and I have this sort of tree that goes there. But they also can present very often to the non-clinician professional. Next slide. And I'm going to try to tailor my presentation more on this arena, because I think most of you will be in the non-clinical professional, mostly entomologists, environmental science officers. So if, for example, there is true infestation, I think then you're very comfortable with knowing how to proceed. But it's really this area where a patient is not infested, truly not infested, that presents this great conundrum. Now, there's a few groups under this not infested group. Oftentimes, the patient has had an encounter with an arthropod that is a non-pathologic arthropod. It's just a household insect. They may have encounters with just environmental debris. People can often have sensations that something is going on, or they can be terrified by articles that appear in the newspapers and on their websites they look at. And many of the people may have been infested, truly infested, let's say with scabies or head lice at one time, but now for one reason or another are afraid that they have become reinfested. Possibly because they have become reinfested, possibly because the original treatment was not successful and the organisms had a sort of a recrudescence of the population, and sometimes just out of understandable worry and concern that they might be reinfested. Next slide. I'm going to continue on to this definitional grounds here. One of the main medical textbooks is Harrison's Textbook of Internal Medicine, and Richard Pollack, the entomologist from Harvard, whom I mentioned a few moments ago, and I write the section on ectoparasitic infestations for about the last 4 editions of this. And this is the wording that we use for this: delusions of infestation. The groundless conviction that one is infested with arthropods or other parasites is extremely difficult to treat, and unfortunately, it is not uncommon. Patients describe uncomfortable sensations of something moving in or on their skin. There's excoriations and self-induced ulcerations that typically accompany the itchiness, the abnormal sensations, and these imagined insect bites. Patients believe that some invisible or as yet undescribed creatures are infesting their skin, clothing, homes, or environment in general. And frequently these patients bring in specimens of the material of the specimens they think are infesting them. And we look at this very often and discover that it's just bits of skin, vegetable matter, lint, textile fibers, or inanimate detritus. Next slide. And when we evaluate patients with this condition, we have to truly rule out infestations and bites by arthropods and other medical and dermatologic and psychological and psychiatric conditions. But many of these patients are so invested in this unwavering belief that there's some parasite infesting them that all these other attempts to look for another explanation go for naught. And these people truly meet the psychiatric definition of delusional, where they persist with a unsupportable belief despite all evidence to the contrary. This is the next line. I'll read directly. Patients with delusory parasitosis, or delusions of infestation, often develop the unshakable conviction that they are infested by a previously unknown pathogen, while their personal lives, family support, and employment collapse around them. And if any of you have worked with families, patients, organizations where they're stuck in this, you know what I mean. There's this inexorable spiral where just life gets worse and worse. Next slide. What's it like to have one of these conditions? This is from one of the websites that look at this. It's difficult to understand the tremendous suffering caused by this condition. The patients feel abandoned by the medical community, and they wind up with these increasingly bizarre, disfiguring lesions that are self-induced, and they have this impasse because the medical community has come to the decision that it's not a true infestation, it's something psychogenic, and the patient doesn't accept that, so they feel this great tension and impasse, and they feel frightened and hopeless. Next slide. One more click here. Okay, so those of you who got Amazon Prime, you can watch this movie, a documentary, Skin Deep, The Battle Over Morgellons, that was produced a couple of years ago, and it has advocates from all sides of the arena who are speaking here about the condition. I think it presents one of these false equivalencies, like here we have the evidence that it exists, that Morgellons is real, and here we have the evidence that it's not real. Well, like a lot of things in politics today, there's a false equivalency there. The evidence that it's not real is huge. The evidence that it's real is either negligible or non-existent. Next slide. But the reviews that appeared online about this documentary are insightful for us. Read the text that's in the red. I will continue to live with this condition and never mention what I feel and what I live with in order to keep the peace and not be labeled as crazy. I isolate myself because many of these people are afraid that they'll infest others, and never mention what I go through on a daily basis to anyone ever anymore. 10 years with no girlfriend, I can't hold a job, and I'm so depressed, but I never show it. I used to be very different. I was an extrovert, great career, witty, fun, had many women in my life, but not anymore. Not at all anymore. I hate my life. I'm so tired of living with this. I'm destined to be alone and tortured every day and every night. I've given in, given up, and lost hope a long time ago. So when you get involved with one of these scenarios, recognize several things. One is that the patient has this fixed belief that's unshakable, and that these patients are feeling psychic stress, agony, that's almost unimaginable. Next slide. So in my presentation at the ESA, I try to focus on clues to distinguish real from imagined ectoparasitic infestations, as if the patient is coming to me, perhaps referred by an emergency medicine doc or their family physician, and I am trying to find out whether or not there truly is an infestation. Obviously, in my field of dermatology, we have a great many patients who are infested with scabies or lice, great many patients who have other reasons to have odd sensations on the skin. I mean, one of the ones that we run across is fiberglass dermatitis from the old-fashioned fiberglass. But as a dermatologist, I kind of have two kind of mottos in this case. One is if there is evidence of infestation, the other physicians will say, well, see your dermatologist. And if there is no evidence of infestation, the other physicians will say, well, see your dermatologist. Next. So the dermatologist's job is to reassess the medical history, repeat the physical examination, look at laboratory evidence, and either obtain or collect the samples from the patient and any other lab evidence to see if we can make or confirm a diagnosis and treat the condition. You get into one of these almost philosophical Thomas Kuhn novel paradigm situations where it's almost impossible to prove that something doesn't exist. And so the patients are always able to say, well, maybe the sample wasn't the right sample. But nevertheless, if we can't find any evidence of an infestation, the patient still has these sensations and concerns and wants treatment for that. Next slide. I'll give you a couple examples. Here's a retired school teacher and a young graduate student. They both report having creatures that live within their skin and move about. They're both reasonably healthy otherwise. They've seen several physicians, including several dermatologists. They've tried a number of treatments, both that have been prescribed and that they've picked up on their own with no improvement in the symptoms. Actually, I should say, oftentimes they have transient symptoms, but they remain concerned that the infestation continues. Next. And to help clear the infestation, the woman uses her fingernails to help remove these creatures that she perceives that are crawling on her forehead. And you can see the linear excoriations there. And the young man has this ritual where every day he uses various household implements, kitchen knives, screwdrivers, to probe into his skin in this very regular pattern. You can see it's almost like a checkerboard here, where he's probing for these lesions, even though he may not, probing for these organisms, even though he may not feel one in this particular area. He has this pattern set up because he believes that these are here, and he goes about doing this. And this particular scar pattern that you see on him is so regular that it's really, nature doesn't do anything like that. Next slide. So when I'm trying to evaluate these patients, I usually try to start out accepting that there is an infestation, and I make a genuine effort to identify any organisms. But keeping in mind the definition for delusions of infestation, you have to have three things: abnormal sensations in the skin, the conviction that the sensations are caused by an infestation, and the lack of evidence to support that conviction. I mean, many people have abnormal sensations in the skin. After all, I mean, all of us have probably scratched our bodies now 15 times in the 15 minutes that I've been speaking, but you don't believe that these are caused by an infestation. Next slide. So the dermatologist's role, next, is to try to find the evidence supporting their claim of being infested. If I can't find any evidence of that, I try to consider, well, maybe the patient was infested, but I can't find anything now. Maybe my technique is not right, or maybe the patient was treated in the past and that the infestation has sort of subsided, but perhaps there's still some organisms there. But maybe there's no infestation at all, but the patient has these sensations that could be caused by an unrelated skin condition. Many skin conditions, poison ivy, psoriasis, can cause these abnormal sensations. Or to identify a non-cutaneous, a non-dermatologic condition that can cause the sensations. And there's many medical diseases. Diabetes, for example, can have neuropathy and give odd sensations. Many medications can produce sensations of itching. And there can be neuropsychiatric explanations that are accepted by a patient. Let's say severe depression. Many people with severe depression can't sleep. They just find everything so annoying. And those explanations might be accepted by the patient. But there's also then the delusions of infestation where the patient does not accept that explanation. So when the patient rejects any other explanation with the unwavering, unalterable belief in infestation, now we're talking about delusions of infestation. Next slide. So when I have a patient who's coming in, and oftentimes the patients who are coming in will have sent letters and made many phone calls and saying they're looking forward to this visit to finally get someone who can make a diagnosis on this, even though my heart is thumping away knowing that this is going to be a long and possibly challenging visit. I take a deep breath. I let the people in the clinic know that this might be a while. And the first visit's often dedicated to establishing a comfortable relationship. And what patients find most frustrating is that most individuals, docs, or whoever it might be, just don't want to hear what is regarded as nonsense. And so I try to be very patient and listen to their tale. People have often not listened to them. Their family doesn't listen to them. And so I will try to listen to them just to find out what's going on, but also to help establish that relationship. And the patients will often bring in these specimens that many of you have seen. And it's likely we're not going to resolve things in one visit. Next slide. There's also a lot of confounders that these patients generally, the ones who have delusions of infestation, truly, they do not disclose that they've already seen a number of other clinicians and entomologists and parasitologists and had pest management professionals coming in. They don't like to reveal how many different medications and remedies they've tried, and the remedies that they're still using, because they're afraid it's going to bias the clinician. So that is usually concealed, which is not a good thing. I try to be open. I hope the patients will be open as well. Next slide. And next slide. There's a long way that I can go through and talk about the way I approach this, but I don't want to delve too deeply into that. But there's the medical history. I've got to find out about medical conditions, prescribed medications, ingested substances, legal and other recreational or otherwise, perhaps illegal, and the substances that are being applied. These medications that are listed in this box here are known to create abnormal sensations. We see a lot of people who have, using crystal meth or cocaine or withdrawal from alcohol or opioids, who wind up getting the sensation of formication, that ants are crawling on the skin. Next slide. And there's many medications that will just cause itch, generalized itchy skin without eruption. Now, sometimes dermatologists will talk about an itch with eruption, where you can see a skin disease, and itch without eruption, where there is no evidence of any skin disease. There's something else inducing this neurological sensation of itch. And so this review article lists dozens of medications that can create an itchy sensation. Many patients who have this sort of recognize, wow, the itch started just when I started this medication. And the doc explained that this is known to happen with this medicine. So I understand it's not as awful as I thought. Maybe I'll change medications, or maybe I'll live with it. But the delusional patient won't accept this. Next slide. And exposures, hobbies, people who do woodworking or work with metal filings, or they're moving fiberglass out of their house, using drywall and cement. Those can all cause environmental reasons to get a severe abnormal sensation in the skin. Travel. A lot of people, especially in the military, think that when they were abroad, they acquired some disease that the less informed physicians back in the mainland, or their military PAs, NPs, and docs don't know about, that they're infested with that, or that a family member brought something back from one of their trips. Next. So I mentioned a couple things here. Pets. A lot of people believe that their pets are the source of this infestation, that their beloved dog or cat or goldfish or frog has brought in some parasite that normally infests non-humans and now has infested them. One of the speakers at our conference at the ESA, Nancy Hinkle, the veterinary entomologist from the University of Georgia, reported on many people who have their animals put down because they believe that the animal is this unrecognized source of the infestation. And here's a book, Is Your Pet Safe? Talking about Morgellons disease, how to decide if your pet is the culprit or not. I also highlighted here, bathing and hygiene habits, because realistically, the most common cause of itching in anyone is excessively dry skin. And the most common cause of excessively dry skin is overbathing, scrubbing, taking hot showers a couple times a day, using harsh soaps, harsh cleansers. That will dry out the skin and create the itch. One of the things we do find in these patients who have the delusions of infestation is they want to be scrupulously hygienic, and they wind up scrubbing more and more, and often using household and industrial cleansers on their skin, which just dries the skin more and makes it even more itchy. Next slide. And there's a number of other focused questions, like cause. It sort of give you some cause and effect. And one question is, what comes first, the sensation or the lesion. A lot of people will feel something, they'll scratch deeply and gouge the skin, and then believe that the excoriation, the trench that they created, is where the pathogen is, but in a sequential analysis, that just is not the case. Next slide. So what does the lesion look like before you scratch? That's called a primary lesion, where it's an unaltered lesion in the skin. Next slide. And here are some examples. Actually, these are all, sorry, the one in the upper left, papular urticaria or insect bites, that is a primary lesion. If a person never scratched, it would look that way. But the other 4 lesions are all secondary. Bloody crusts, you can see in a linear array like the person's been scratching. Prurigo nodules, which are just when someone picks at a particular area over and over again, it gets thick and almost scar-like. Lichenification is the thickening of the skin from continuous or constant mild rubbing and scratching. And then the lower right, erosions and bloody crusts. One of the important things here is that it spares the middle of the back where a person has trouble reaching. And that's a clue that there's not something external or biologic causing this, that this is self-induced. Next slide. Just another close-up of the grad student who sort of devotes many minutes or hours of his day to probe his skin looking for creatures. Next slide. And I find that many patients deny scratching. I think they may feel that if they tell the doc that they're scratching, the doc will automatically jump to the conclusion that, it's the scratching that's doing this. But so patients often deny this, but I find several things that I look at, and that's clusters of excoriations. If you see 3 or 4 lines that are roughly the same length, caliber, equidistant throughout, appear to be the same age, that's from scratching like this. All right, I guess you can see me. Everyone do this, scratch yourself. You'll have either 3 fingers or 4 that will create those parallel lines of the same caliber. And I also find that if you were to look at the direction that those lines are, they will point to the opposite elbow in the scratching position. And I mentioned look for blood under the fingernails, if there's a sparing in the middle of the back, and if the non-dominant side has more lesions. Like if you're a right-handed person, you might expect more sores on the left. Next slide. Next slide. And I like to ask the patient, what do you think is going on? Now, I admit that this may not necessarily get me closer to the answer, because I probably may know the answer already, but I am just fascinated by how devastating the condition is to the person. I want to know, do they think they got it from their pets, from travel? Do they keep logbooks? Have they bought their own microscopes? What are they doing? Do they travel? Do they stay at different lodging? I have a patient who was the dean of a college at one of the major universities in the DC area who has this, and she no longer works at the university, but she tries to stay at a different place every night, and has sold her grand home in Washington in Foxhall, and has gone through her complete retirement savings and the equity from her home just in staying in new lodgings every night, and or every few nights. She'll stay there for a couple nights, and when she feels this again, she'll believe that she's infested that room and she'll move somewhere else. Next slide. And what has this done to your interpersonal relations? I mentioned that this dean of a college had left her position, probably unable to continue the job. But and for most of these people, their health, their intimate relations, their social relations, their work relations, all spiral downward. And many of the individuals believe they're contagious, and they deliberately isolate themselves. And oftentimes people wind up convincing other members of the family that there's infestation throughout the house. Next slide. And what are patients doing to treat themselves? They often can get prescription medications, but I find that, and a lot will get OTCs, and a lot will go on the internet and find things, but many of them will get veterinary medications. I'd say that maybe a quarter of the patients that I've seen with this get veterinary ivermectin and treat themselves with that. They'll ingest the paste, they'll get the oral stuff that's given to animals, they'll inject the ivermectin thinking that it will help them. And I'll go over this a little bit more later, but oftentimes the patients will tell me something like, I take that ivermectin tablet, and the moment I put it on my tongue, I can feel the creatures leaving my body. So that's biologically not plausible, and that's a clue that this may be delusional. Next slide. And another thing that I found is that although these are unusual sensations, I find that most of my patients cannot provide an adequate explanation of what they are. Like they may say, I feel something crawling in my skin. And I'll ask, well, does that bother you? What does it feel like? They say, well, it feels like something crawling in my skin. And, you know, we'll talk about how everyone's got things on their skin. They've got clothing on the skin. You've got bacteria. You've got fungus. You've got mites on your skin. And we don't feel that, or it doesn't bother us. But they say, no, but I don't want this in me. Meaning, I cannot get many of these patients to actually say, it itches, it's painful, I'm worried about getting malaria from this. They just say, I sense something is there and I don't want it to be there. Next slide. They focus more on things being unwanted than on things being disturbing. Next slide. Next. All right. And of course, we go through an evaluation for ectoparasitic infestation with scabies and lice are most common. And I'll run through some of the bits of evidence of infestation for true infestations. Next. Next. One of the common ones, of course, is head lice. In many ways, you could argue that head lice are inconsequential from a public health standpoint, in that head lice do not transmit diseases. But if any of you are parents and you know what happens when a child in school gets head lice, this gets to be a catastrophic event. So we wind up seeing a lot of people with head lice, and we treat that. Next slide. We see a lot of people with scabies, and the best way to make a diagnosis of scabies is to see the burrows, which are extremely hard to find. This is the best picture that I've ever taken of burrows, best picture I've ever seen. And we look for typical locations, distribution, and the persistent itch. Next slide. There's an organization that started about 10 years ago, the International Alliance for the Control of Scabies, that consists of physicians and entomologists and public health workers. And the World Health Organization has declared scabies to be a neglected tropical disease. It's not so much that scabies causes the persistent itch, which is bad enough, but it's that scabies is the initial avenue or portal of entry for many invasive bacteria, staph and strep in particular, and you get a lot of downstream consequences from those bacterial infections. So that group is actually going to meet at the ASTMH meeting in November this year here in DC. And we've come up with the criteria that we want to use for the diagnosis of scabies. Next slide. And we'd like to see typical lesions. As you can see, none of these individuals have burrows, and almost everyone on the 4 slides to your left look like they've got secondary bacterial infections. There's pus there. This volar or palm side of the wrist is the most common location to have scabies. If I see someone who's being evaluated for scabies referred by another doctor, they think they have it and they have nothing on this part of the wrist, I think it's essentially you don't have scabies. The other body part that is almost always invariably infested in males is the genitals, the glands or head of the penis, the corona, the shaft, and the scrotum. Sooner or later, any male over the age of maybe 1 year who has scabies is going to transmit them to the genital area. And here, the lesions look a little different. They're called nodular scabies, and they produce these sort of thickened bits of skin there, and they're often not itchy or not very itchy, so they don't look like scabies elsewhere. So when I'm evaluating someone for scabies, a male, one of the first things I'll do is ask to do the genital exam, and if they have this, that's it. We've got a diagnosis. Next slide. I just want to mention something about treatment for scabies. You know, a patient may tell you that I itch, but I don't think it could be scabies because I was treated for it. Well, looking at the cross-section of the skin, the scabies mite and the eggs are in the part of the epidermis. So if a person is treated for scabies and treated properly with whatever the proper treatment is going to be, let's say permethrin and ivermectin, the scabies mite, now dead, remains in the epidermis for about 2 weeks before the skin turns over, and the mites, the adult mites and the eggs are lost, are shed. So the person itches when they have live scabies because of a hypersensitive reaction to the live mites, but they continue to itch for about 2 weeks after successful treatment because of a hypersensitivity reaction to a dead mite. So no one, never let someone believe they should feel better, right away after scabies treatments. Next slide. And I do want to mention crusted scabies. This is an unusual form that you may not have encountered, but it's often in someone who's got neurologic disabilities or perhaps physical disabilities like a paraplegia, where they're not able to scratch or respond to the scabies mites, and the scabies mites just produce these metropoli there with literally millions of scabies mites there. Now, the average scabies infestation only brings about 10 to 20 scabies mites on a person, and that's miserable enough. Paradoxically, these people with millions of scabies mites often don't feel itchy at all, but they develop this sort of sandy colored, gritty dust on their skin that's just teeming with organisms. And these are the individuals that are the nidus for outbreaks of scabies. So I've been in a number of situations with military, with public health interventions where we're overseas, we're trying to treat a community that has scabies, but discover that some great-grandmother who had a stroke, who's still living in the hut or the village, has crusted scabies, and that we'll never get rid of scabies in that community until we actually get rid of the crusts on her and treat her scabies as well. So that's the nidus for reinfestation. Next slide. And my entomology colleagues remind me that some of these Dermestes larvae have these setae that can be very annoying and can give odd sensations. Next slide. And these slides are from Rich Pollack from Harvard. Next slide. And the entomologists and parasitologists I work with report that when people submit specimens, these are the typical specimens: ticks, fleas, lice, free-living arthropods. Next slide. So those can be real infestations, but they're also pseudo-parasites, and these can be things that are just found in the toilet, in the house, in the carpet, in the furniture that are submitted nevertheless, and you probably get involved with this sort of thing. These slides are from Bobby Pritt from Mayo Clinic, and unfortunately, many of the specimens are submitted are just, as Rich Pollack says, scabs, skin fragments, and snot, things that people pull out of their nose and send to him. Next slide. But true arthropod bites can produce several reactions. You get papular urticaria, which is the fancy term for the edematous wheal or welt that comes from a typical bite of a hematophagous insect. And always look for these features. There's redness, there's some edema or slightly elevated. They often have a central punctum where the bite occurred. The crops are roughly of the same stage of development, the same time of origin. They resolve roughly at the same time. And the skin is itchy, but the skin between the lesions is not. And those things may seem so obvious, but they're very useful because many people just confuse stuff. Okay, next slide. So we talked about this issue of distinguishing scabies bites from other true infestations. I looked for the volar wrists and the male genitalia, and the difference, the distinction is really important because scabies infest the individual, and let's say animal mites, Chilatiella, they don't infest the individual directly. They may feed ectopically on the person. So when you have someone with scabies, you want to treat the individual. When there's an environmental mite, a bird mite, a straw mite, flower mite, then you want to find the source and respond to that. Next slide. So here's another example of someone who believes he's infested with hundreds of ticks. Next slide. And there's a close-up. These are photos from the individual. This was actually me. I must have stepped on a little egg packet of from Amblyomma americanum when they were ready to burst forth. And I had over 300 ticks on me on my left leg from knee down. They left these bites here, probably over a total of 1,000 ticks that had bit me. But we'll say that I'm not delusional, that this is truly an infestation. Next slide. This is a case that I worked for the State Department and the Peace Corps and a few other agencies trying to help them sort things through. There was a State Department employee at an Eastern European embassy who was going to be evacuated, repatriated from that country to the U.S. because the State Department physician felt she was delusional, thought she had delusions of parasitosis. But we got involved and looked at these pictures, and they fit all my criteria for a true lesion. And we found that she had, that she had what we call the comet sign, which is this sort of linear streak that comes out in an unusual direction from the side of the bite. And that's very typical of, next slide, of Pyomotes ventricosus, a furniture mite that's particularly common in Europe. We've seen a few patients here who get this comet sign, but as of currently, it's considered essentially a diagnostic sign for a mite bite and not an insect bite. Next slide. And then patients will, of course, learn that they've got Demodex on them and get quite alarmed by that. There's TV shows and websites that discuss this. Next slide. And, you know, when you see a picture of a Demodex, you certainly do want to eradicate those. It takes a bit of persuading even for probably our entomologists and dermatologists to accept them as symbionts. Next slide. And then when I can't find any evidence of a true infestation, an arthropod there, I will go through and look for dermatologic causes. What are the people doing? What are they applying to your skin? What skin diseases do they have that might explain the odd sensations? Next slide. Next. And here's a list of things that can cause either central itch or peripheral itch. Peripheral itch means that there's something like fiberglass or poison ivy that's making you itchy. Central itch could be something like a nutritional disorder, endocrinologic disorder, neurologic disorder that makes you feel itchy. It's from the brain going out. Next slide. And then I will finally get to looking for evidence of delusional disease. We went through some of these things, whether what the scratch marks are like, whether there's blood underneath the fingernails, whether they were pulling on their hair or their eyelashes. Next slide. And these notebooks. Many of you probably have seen patients who've submitted logbooks that, you know, are like better than your PhD logbooks with the fine details they have there. It's usually just, like I said, environmental debris. Here we have some, you know, sort of plant hairs that we can find in there. Next slide. Are there any lab tests that we will do? Okay. Lab tests. Yeah, there's a number of lab tests that could be useful. Many times the patients want a lot more lab tests to be done, and they want material sent to the CDC and that sort of thing. You don't need to get involved with that. Next slide. And next slide. So what do we do with the materials that are in the matchbox? They used to call it the matchbox sign. Now it's probably the Ziploc bag sign. One thing that I will do that I don't necessarily recommend for other people, but I will pull out a two-headed microscope into the patient exam room and have the patient identify 2 or 3 specimens or critters that they are most convinced will convince me. And we look at those together. I think you have to be comfortable with microscopy. You have to be comfortable knowing like what truly is an arthropod or arthropod part or you know, cast or something like that in order to do this. And most physicians will send the material to someone like you or a pathologist. The pathologists are very in their expertise. Bobby Pritt at the Mayo Clinic, I'd be happy to send any specimen to her. Otherwise, I think sending them to an entomologist or parasitologist is worthwhile. Next slide. Skin biopsy. We often wind up doing skin biopsies, but I want the patient to show me something that is a primary lesion. I want them to show me something that hasn't been excoriated, because I know that if they've scratched themselves and there's a little bit of serum that oozes out, they're going to get textile fibers there. And the CDC, next slide. The CDC conducted a study, and I'll go over it a bit more in a moment, and they found that I think in like 104 of 105 patients, the fibers that were found were all textile fibers in open sores. So in my overall assessment, I do wonder if there's a trigger event. Is the patient doctor shopping? Are they using non-traditional therapies? Are they moving from house to house and destroying belongings? Do they use industrial pesticides? Is there folie à deux or folie à famille, which is meaning is the delusion shared by other people in the household? And I'm always interested in these elaborate descriptions of the parasites that the patients will give. Next slide. So the CDC conducted this study. The CDC conducted a study out in the Kaiser system in California and examined hundreds of patients. And actually, some of the people from AFIP worked on this, and they did mass spectrometry and gas chromatography and electron microscopy and all these tests. And like I said, they found textile fibers in essentially all but one, and most of the patients had an existing history of substantial psychiatric or mood disorder. And so the CDC concluded that this unexplained dermopathy is not anything external, and that it's a psychogenic condition, and the CDC now doesn't want anything to do with these patients or this condition at all, because it's a time suck. Next slide. So here's just some photos from the CDC paper. I was actually one of the reviewers for that, but you can see the fibers that they find in the individuals. They'll tease them out and then run a mass spec on them and find that they're just cellulose from textiles. Next slide. Sorry. Some patients, when you explain that you haven't found anything, they'll have insight and they'll accept the diagnosis. Some will even say, accept that you might conclude that it's perhaps related to psychological or psychiatric issues. but next slide. Some patients don't, and you can find so much on the internet. About Morgellons in particular, but you'll see from this, if you can read it, that 80% of people with skin sensations have Morgellons. A lot of them, 80% have collembola or collembola, and some have strongyloides that they propose, and something that I hadn't heard of before, strepsiptera. Let me get that, strepsiptera, and many of my patients will also tell me that they found out that they believe that it's not an insect, but they come up with some hypothetical organism. Next slide. That is this biologically implausible explanation where you have this fanciful amalgamation of mutable features. Well, it's a hyphae one day, and the next day it has wings, and the next day it has a proboscis, and the next day it's invisible. And it's this composite of taxonomically unrelated organisms that shapeshift. And as I said before, many people believe their sensations start to abate as soon as they take a medication. I mean, as soon as they put the medication on their tongue. So a lot of implausibility here. Next slide. And these are some of the other findings that that lead me to feel more and more comfortable assessing this as delusional. Next slide. And wrapping up the visit is a difficult process. We usually have to invite the patient back, but there's a lot of diplomacy involved in discussing this with the patient. And one of the things that I find is that I always feel that a rational individual, if they have an unexplained symptom, will often accept some other feature. Like, I think my shoulder hurts and I can't get it better through physical therapy. And someone says, you know, there's an odd endocrinologic disease that might do that. Would you consider that? I'd say, I don't think so, but yeah, let's look at that because nothing else has worked. These individuals will not waver from the belief that it's this infesting parasite. Next slide. So palliative treatment, I try to get people to treat their skin gently. One of the first things I want to do is get them to stop scrubbing with so many other cleansers and stop using the over-the-counter or veterinary medications. Next slide. But I went on to Amazon Books and looked up Morgellons, and there are dozens of books, mostly self-published, about Morgellons. Next slide. Here are some. The Year of the Mite, interesting study, or paid book. That's by someone who's actually, I think, like a medical technologist who believes she has this, and she writes in a little bit more sophisticated level. Next slide. And I find this one here on the right quite interesting. A case study, infected by military nanobots. So that's probably you guys doing this. Morgellons is caused by nanotechnology. Next slide. And I acquired the infection where the military is testing new technologies. Next slide. And so I'm just wondering, I'd love to hear your responses and your contributions and comments. I know that many of you have been in this situation before, and this group that put on the symposium at the ESA, we really are trying to make a cross-disciplinary approach to this and include a lot of people with pest management professionals and entomologists who often encounter these families and patients and try to come up with some unified approach to this. If you've got concrete recommendations or interest, please email me at the email address that's on my last slide. I'm using scottannorton@gmail.com for my email currently. Okay, can I turn this over to the moderators and see if there's questions?
Hi, Dr. Norton. This is Gabby Zollner. Thank you very much for a really fascinating presentation with lots of information. And I realize there's a lot of ground to cover here. So thank you for covering everything. So we do have a few questions from the chat, and so we can go through those first. And I think some folks are also adding questions as I speak. So we have a few minutes for the chat, and then we'll move over to the phone and see if anyone has questions who dialed in. So the first question from the chat is, do some cases of delusions of infestations include the sensation of internal parasitism, like a gastrointestinal parasite, as well as the dermatological infestation?
That's an excellent question. And we get into this nomenclatural debate all the time when we're working together. And the psychiatrists want to use one term, and they really push towards infestation, which implies morely external or cutaneous. But a number of my patients believe that these are hematologic organisms, or that will be intraocular, intracerebral, and they have a lot of systemic symptoms as well. So in a way, abdominal pain or diarrhea, something like that. A diarrhea, truly, you've got physical evidence. Abdominal pain, it's a little bit harder to figure out. But yes, people do believe they may have purely internal or combination of internal and external, or purely external. Yes.
All right, thank you. And then the next question is, do a significant percentage of cases have a concurrent diagnosis of one or more allergies together with the associated dermatitis?
Yes, that's a good question. There's immunologically, there's several types of allergy, and we know that many of the patients will have what we can call a contact dermatitis. It can be a contact dermatitis that's an allergic one to some compound that they're exposed to, a preservative in their moisturizer. And they can also have an irritant contact dermatitis that's technically not an allergy, but if they have some substance like a cement powder on their skin, or just very dry skin. As far as allergies like hay fever and that sort of thing, yeah, many people do, and they'll develop urticaria or hives, maybe from ingesting something that gives them skin sensations as well. But usually people get tested for that, and that group who have true allergies can probably be separated out. I don't think these individuals necessarily have any more allergies than other people.
Okay, thank you. And the next question is, have you seen toxicity from self-treatment?
Oh, sure. Toxicity from self-treatment. Yes, I mean, there can be this almost like psychological obsession where a person feels like they're dependent on something, and it just alters their life, where they feel that they must bathe in, or put ivermectin paste on their skin, like the oral paste, rub it on their skin, and so they become very dependent. And there have been reports of various toxicities and medication interactions. As far as ultra serious ones, some people, use organophosphate insecticides, and there have been a few problems with that, probably far more than have been reported. But yes, that does occur.
Right, thank you. The next question is, can you address chiggers in more detail, the signs to look out for?
Well, chiggers, the trombiculid or leptotrombiculid mites, that's in a way an easy disease to work with, because it's either there or not there. And there's no subacute carriers of that. So I actually gave a talk on mite associated dermatologic problems at the AFPMB several years ago, and maybe we can look at that later. But I think chiggers, I don't really see that as a real part of the confusion with delusions parasitosis. People with chiggers, they got them.
All right, thank you very much. So that's all the questions that we had in the chat box. I'll turn it over to folks who are on the phone in case there are any questions from people on the phone.
Well, I would like to invite people to email me at scottannorton@gmail.com with other questions or contributions, insights, articles, your experience, and if anyone is interested in working with our ESA symposium team on trying to come up with a master document on this. And also, I've been involved in a couple cases with the military. Well, I see that Silas Davidson was on this, and he and I worked on blister beetle outbreak in Iraq, and Jeff Clark and I worked on a sort of unexplained mite dermatitis in New Orleans after Hurricane Katrina. But others of you have contacted me because of alleged outbreaks of scabies in schools on military bases that where all the parents felt that it was like the kids were being swept with scabies. These turned out to be either psychologic, like mass hysteria, or something environmental, like dust and powder. But I would be very interested to hear more experiences of this group that assembled for the talk. And once again, I want to thank Gabby and the rest of your group for inviting me to speak before this group of entomologists.
Right. Thank you very much, Dr. Norton. I'll ask everyone else who has questions to email you directly, and maybe we can continue the conversation that way. So thanks again, and thank you from our audience as well.
You're very welcome. Thank you.